From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Welcome to the JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Social Vulnerability in Prevalence and Treatment for Mental Health and Substance Use Disorders. We're about to be joined by the first and senior authors of the paper, Dr. Robert D. Gibbons, PhD from the University of Chicago, and Dr. Ronald Kessler, PhD from Harvard University. Today, there's increased awareness of how social vulnerability impacts mental health. What is the exact relationship between social vulnerability, or say environmental deprivation, and outcomes like depression and anxiety that our patients experience? To find out, we'll explore the results of a brand new study just out in JAMA Psychiatry. Thank you both, Dr. Gibbons and Dr. Kessler, for joining us. And I want to jump in. We've all heard of these terms around social vulnerability, but what does this actually mean?
Social vulnerability is defined as the negative effect on communities due to external stressors. And it's a nuanced term. A community is vulnerable if the people living in that community are in a situation where a mass trauma, for example, some natural disaster or public health crisis, would have a big effect on them. And the reason why it's an important concept is that it helps us to direct resources to specific communities that lack the resiliency following an adverse community event.
In your paper, you note social vulnerability has garnered broader interest in public health due to its close relationship with social determinants of health. How are social determinants of health related, the same, or different from social vulnerability?
It's a great question, and again, a very nuanced answer. Social vulnerability links directly to social determinants of health, or SDOH, in terms of social vulnerability's relationship with health outcomes. Now, social factors are important in terms of leading to differential exposure. Some communities have higher risk of exposure to some stressors and reactivity. A mass trauma would have a bigger effect on a more vulnerable community. Statistically, social determinants of health are about both main effects and interactions. And social vulnerability is really just about interactions. That is the reactivity to stressors. As a result, social vulnerability represents a subset of social factors that are the elements of social determinants of health.
What do we understand today? Before your research, we'll talk about the new results that you and Dr. Kessler found, but what do we understand about that relationship between social vulnerability and mental health outcomes before your work?
Much of what we knew came from social surveys where participants were asked about their mental health history. For example, have you ever been diagnosed with a mental health disorder, or have you ever been treated for a mental health disorder? In general, those studies have found relationships between social vulnerability and affective disorders. Our study goes beyond the existing research by using mental health and substance use disorder diagnoses that are derived from gold standard structured clinical interviews in a national sample. And let me pass it to Ron to explain further.
Thanks, Robert. We showed in this study that social factors are associated with aggregate differences in prevalence of mental illness geographically. But I think it's important for us to be clear that we're kind of taking a first step here in looking at social vulnerability. These differences we found could be due to selection. So, for example, we looked at some neighborhood and community level factors. If it turns out that there's a lot of people with schizophrenia who live on the Bowery, that doesn't mean that living on the Bowery is a cause of schizophrenia. It could be the other way around, so selection bias. And the other possibilities, of course, are that there's this higher exposure to stressors as opposed to higher reactivity to stressors. And we just don't know from the data we looked at here and the associations we've documented. But what we do know from our work is that the aggregate differences of the sort that we documented existed. This opens up further research opportunities looking at decomposing that aggregate effect. How much of it is due to selection? How much to differential exposure, differential vulnerability? And another important thing it's worth highlighting that Robert and I have talked about subsequently is that This line of analysis allows us to look at outliers accurately. So there are some areas that are actually doing much better in terms of mental health than are predicted by our model, and some doing much worse. And these are places where doing qualitative research to figure out what the heck is going on in these places that we could export to other places that have seemingly high risk factors on a structural level that are not doing as well. So it gives opportunities for exploration, for intervention possibilities.
We know there's been a lot of cross-sectional research before looking at the relationship between social vulnerability and mental health. But as both of you said, there's been some selection bias. There's things that we can't learn from the past research. You also outlined, Dr. Kessler, how if we had better data, it could be more useful for kind of precision allocating resources, helping build programs. How would that better understanding of social vulnerability be useful overall? If we actually knew this answer, what would you see happening?
Our study demonstrates associations between social vulnerability and the prevalence of mental health disorders and substance use disorders. And our analyses also indicate that increased social vulnerability is associated with decreased mental health and substance use disorder treatment for individuals with specific conditions like schizophrenia spectrum disorder, opioid use disorder, stimulant use disorder. What's important for a better understanding is that additional resources are going to be needed in socially vulnerable communities to develop the service capacities that are needed to ensure equitable treatment rates between those communities that are vulnerable and not vulnerable. Our paper leads to that better understanding and the potential for the direction of those resources.
That's kind of a critical thing. I think it's also important to highlight that by focusing on aspects of community differences that are modifiable, our results can start creating some scaffolding to help design and target interventions, give some insights into what are the kinds of things that governments could do to go in and intervene with vulnerable communities that are doing worse or rather than better in the ways that we've found here.
To dive into your results and what you found, a first step is to understand the social vulnerability metric, or SVM, social vulnerability metric. This is a new metric you use in the paper. What exactly is it?
The social vulnerability metric is the first model-based measure of social vulnerability. Traditional measures like the Social Vulnerability Index from the CDC or the Area Deprivation Index, they select a series of putative indicators of social vulnerability or social determinants of health and simply sum the individual item scores to derive a total score, or do so within domains to derive a domain score. By contrast, the social vulnerability metric uses multidimensional item response theory to differentially weight the items in terms of their ability to differentiate high and low levels of social vulnerability and how easily satisfaction with the item is achieved, kind of the difficulty of the item, if you will. And these weights increase the precision of estimation. They produce stronger associations with relevant health outcomes. And importantly, the IRT model, the item response theory model, also identifies items that are inconsistent with the underlying latent variable of interest, so they can be eliminated from the SVM, which also improves the quality of measurement.
We have this new metric, the social vulnerability metric, SVM. You've helped us understand there's, of course, a relationship to mental health, but we don't have the best data on it. So to really help us move the field forward, you guys use a very interesting and large data set. Can you tell us about what was the data set you used for this work?
This is a study carried out by Research Triangle Institute in conjunction with their work administering for SAMHSA, the National Household Survey on Drug Abuse, which is done every year, a very large sample. I think around 70,000 people, face-to-face household interview. This was a pilot for a new vision of what that survey could be. It's called the NISDA survey, could be done in the future. And it was a survey of over 20,000 households in America. The idea being to, as Robert mentioned earlier, to get a really diagnostic interview with people. And the way it was done was by developing short screening questions that were administered to random samples of people in these 20,000 households in the country to see, in a predictive sense, who are the people who have a high likelihood of having a serious mental illness, some likelihood, and a low likelihood. And then we differentially sample across those 20,000 people to get 5,000 who were administered a SCID interview, a structured clinical interview by telephone, by a highly trained centralized staff of clinical interviewers, and then using complex weighting procedures to generate estimates, small area estimates, of the prevalence of these clinically significant disorders in communities and block groups and counties in America, so that this multi-level model could be imposed on the data. Now, we have to be cautious about the results because, unfortunately, the COVID pandemic occurred right in the middle of the study. So the design was interrupted. The plan originally was to do all of this stuff face-to-face, and it turns out we had to do it by telephone and by mail, and it was a relatively low response rate. But even with those difficult conditions, the main goal of the study was to demonstrate a proof of concept that this can be done, and we showed quite clearly that we can do this. We can screen effectively. We can come up with good estimates of point prevalence of small areas in a multi-stage clustered stratified area probability sample of the U.S. household population, pull out a truly clinical study as opposed to a merely descriptive epidemiological study.
From this very rigorous approach, how many people and who was the study population that you collected this rigorous data on?
Well, it was adults, so 18 and above, people living in households. It was a multi-stage clustered area probability sample, so a very rigorous study based on all the addresses. There's a master address file for every address in the United States, and that file was used to draw a sample that was representative of all the households in areas that are representative of the United States. Another important piece of the study, which I'll throw in a pitch for RTI, although it's not used here, is if you're interested in really seriously impaired people, even though the great majority of the U.S. population lives in households, a substantial percentage of seriously impaired people do not live in households. They're homeless, or they're in jail, or they're in nursing homes or prisons. This sample did pilot versions of trying to get a total population sample, which is to say that it not only went to a nationally representative sample of households, but it went to prisons and jails, it went to nursing homes, and it went to homeless shelters. And again, we were able to show that it's possible to go into a systematic sample of those kind of places, enumerate people who are there, do screens, and administered structured clinical interviews. So the technology is now there to do this stuff on an ongoing basis. Our hope is that the government follows through and uses this pilot as the basis for doing this in the future so we can get more rigorous estimates of these multi-level area things than we have right now. I think at the moment, Robert would agree that the results are too thin for us to base policy decisions on them, but what we've done, I think, very clearly is show that it's possible to use this design going forward to build up a stronger sample over the course of time so that we can really use these area level vulnerability things for real policy purposes.
What are the main outcomes of interest that you are going to be collecting in this study that we're going to learn about?
The main outcomes in the study were individual level variables for mental health and substance use disorder, DSM-5 diagnoses, and treatment that was received in the past 12 months, which were assessed by the SCID remotely via telephone using trained and closely supervised clinical interviewers. And the diagnoses that we assessed included schizophrenia spectrum disorder, major depressive disorder, bipolar 1 disorder, generalized anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, alcohol use disorder, sedative use disorder, cannabis use disorder, stimulant use disorder, and opioid use disorder. And we also analyzed 2 treatment indicators, any mental health treatment and any substance use disorder treatment. That's
a lot of outcomes, but also I know in the paper you have a lot of covariates to assess because you're trying to look at, again, social vulnerability and mental health. There's a lot of things you're going to have to try to control for. So maybe let's review what are kind of the main covariates that you assessed and wanted to include.
So our primary independent variable were zip code level estimates of the social vulnerability metric, the SVM. And the SVM is a composite measure developed from over 200 social determinants of health indicators from the 2018 AHRQ SDOH database. And the variables cover social, economic, education, built environment, and healthcare. And as a comparator to the SVM, we also use the Area Deprivation Index, which provides a neighborhood ranking based on socioeconomic disadvantage. It's important to note that neither the SVM nor the ADI included race or ethnicity in their construction. In addition, covariates that we adjusted for in the analysis included zip code population size, which affects the precision of the SVM scores, and individual level confounders measured in the MDPS, like living alone or age and gender, race, and ethnicity. But we also, in a sensitivity analysis, adjusted for zip code level composition of Black, Hispanic, American Indian, Alaskan Native, and Asian residents to determine whether or not the SVM performance varied by racial and ethnic neighborhood composition.
It's sometimes hard to cover so many covariates and so many outcomes, but I think that's a good summary. And again, I'll refer people to the paper for even more details. But perhaps now the question we've all been waiting for. There's a lot of important, interesting results from this rigorous study. What are the top 3 that you would want listeners to be aware of?
In contrast to previous studies using non-clinical symptom-based survey data, we found no association between social vulnerability and generalized anxiety disorder or major depressive disorder, the 2 main affective disorders. That was a really important and surprising finding. However, there were very strong associations of social vulnerability with the prevalence of schizophrenia spectrum disorder, stimulant use disorder, and opioid use disorder. And importantly, people with these disorders reported corresponding decreases in treatment. But again, caution is needed because of the low response rate and the fact that the study was done during the time of COVID.
Are there other important results you want listeners to be aware of?
I think it's important to emphasize methodological results too. I mentioned this briefly before, but it's important to realize that the complex design of this sort can be pulled off, that it is possible to get an overall national portrait of clinically significant mental disorder at small areas. And secondly, that we documented these strong associations of small area level variables. Robert mentioned that it's at the zip code level, but it's also possible to do things at block group levels and census tract levels, but in neighborhood you could think of, to be able to show there's certain neighborhoods and certain communities that have higher rates of mental illness than others based on structural characteristics that are potentially modifiable. So we can and should build on these results to initiate studies of neighborhood and community level social determinants of health, including vulnerability factors. And as I mentioned before, the possibility of case studies to get insights into potentially effective neighborhood and community level interventions to figure out why is it that some places in this scheme seem to be doing a heck of a lot better than others, even though structurally they look like they should be disadvantaged areas.
Which of these results surprised you the most?
Certainly for me, the absence of an association between social vulnerability and affective disorders was very surprising, particularly given the existing literature. And we attribute this to an improved quality of measurement, both in terms of social vulnerability as well as in terms of coming up with diagnoses of these disorders based on structured clinical interviews using DSM-5 as opposed to patient self-report of their experiences.
For these results, clearly they have implications for policy. What would you want policymakers to take from this work and begin to think about or maybe even implement?
As I mentioned before, it's premature to implement things based on this study. This particular study was designed specifically to be a pilot, albeit a very large pilot. We need a replication and expansion, at a time when we can implement the full initially intended design, which we were not able to do because of COVID, as I mentioned. That would yield a much bigger response rate, higher response rate, allow us to confirm the stability of the results before making any policy recommendations. But once that's done, major funding sources that could be used to support several expansions in high vulnerability areas, including things like state opioid settlement funds, substance abuse, mental health service administration grants, Medicaid, 1115 section waivers, and so forth. There's lots and lots of critical policy relevant community level social determinants vulnerability initiatives that can be driven by this stuff going forward.
How would you want clinicians or patients reading the paper, listening to the podcast to act on these results or begin to think about the influence?
Integrating social vulnerability of health into federal quality improvement programs and healthcare quality initiatives could also improve healthcare providers' response to community mental health and substance abuse disorder needs. So that's something that's really critical. For now, the social determinants of health literature, as you know, is in a relatively primitive space. There's a lot of work going on to figure out how we could use these kind of things. There's a couple of papers that are in the works right now about reviewing these kind of things. But we now know for sure that there are high-risk neighborhoods. They can be documented. There are other outlier neighborhoods that should be high risk according to our things, but are seen to be doing very well, and we don't know why. And that opens up a whole interesting possibility for developing interventions that could have big mental health implications in the future.
I think that's a nice place to conclude, in that there's a lot more we have to learn, and research like this is helping advance us, but I think we're going to see continued excellent research coming out, building upon these results that you have. So I'm John Torous, and I've been speaking with Dr. Gibbons and Dr. Kessler about social vulnerability in the prevalence and treatment for mental health and substance use disorders. You can find a link to the article in the episode description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thanks for listening.